Hey everybody, Dr. Rob Silverman here. I'm excited to share the next 55 minutes with you. We've got a great presentation. I want to thank A4M for allowing me to be here. I appreciate KBMO Diagnostics and all that they do. They are my sponsor, and we're going to talk about some of their tests. And I am not going to keep my camera on the whole time. I don't want to distract you from the slide deck. So off goes the camera. And let's get started. Let's talk all about gut matters. Let's speak about revealing the connection between the gut and cardiovascular health. I believe the gut is the epicenter of your health. When the gut microbiome is out of balance or inflamed, the impact is felt throughout the body, including the cardiovascular system. If the gut is healthy and functioning properly, the microbial metabolites, such as lipopolysaccharide, i.e. LPS, and other antigens are appropriately contained within the gut lumen. However, a dysfunctional, permeable intestinal barrier allows microbial antigens and metabolites to be translocated from the gut into the bloodstream. Once intestinal permeability allows LPS and its associated antigens to escape into circulation, they can trigger immune response inflammation that contributes to insulin resistance, hypertension, atherosclerosis, coronary artery disease, atrial fib, and cardiomyopathy. My goal is to lead you through this intricate interplay between the gut microbiota composition, gut permeability, immune inflammatory responses, metabolic pathways, and the collective influence on cardiovascular well-being. My goal is to share a thorough understanding of new functional medicine strategies for improved GI function and how they can help reduce cardiovascular risk and lead to optimum health. Hopefully, at the end of this presentation, I will share with you some clinical approaches, treatment protocols for restored damaged barriers, eliminating gut dysbiosis, and also helping cardiovascular health. So let's dig in and let's get started. Over 2,000 years ago, Hippocrates said, all disease begins in the gut. 20 years ago, Dr. Alessio Fasano, who found the zonulin protein enzyme, stated, all disease begins in the leaky gut. Without question, they both were right. So with this particular slide, this really emphasizes the idea of dysbiosis. Well, what is dysbiosis? Dysbiosis is the unleveling of good and bad bacteria. You need about 85.1% of good bacteria not to be dysbiotic. Dysbiosis, I believe, may be the bane of our gut existence. I think dysbiosis may be the nexus that causes all things going aberrant in the gut. Dysbiosis clearly increases gut permeability. And when we talk about gut permeability, let's talk about gut permeability from a tight junction function and also epithelial cell. LPS, which is an endotoxin, which we'll talk about extensively in this presentation, when it translocates through the gut, it attaches and stimulates toll-like receptor 4, which stimulates oxidative stress, which is a contributing cause of cardiovascular disease. In addition to that, it also stimulates cholesterol accumulation, fibrosis and inflammation, regular inflammation, combining with oxidative stress, contributing even more to cardiovascular disease. So this is a very simple example of how the gut can adversely affect your cardiovascular health. Let's talk about some mechanisms of gut permeability, or if you will, mediated low-grade endotoxemia. On the right side, we've got A, and then, well, in the center we have A, on the right side we have B. But overall, the gut epithelial barrier consists of the apical plasma membrane of enterocytes held together by tight junction proteins. These tight junction proteins are actually claudin and occludin, and adherence junction proteins, as well as zonulin, which are adapter proteins necessary for structure and regulatory function of the tight junctions. Letter A shows the upregulation of junctional proteins can be induced by microbial metabolites, including polyphenols, indole derivatives, and short-chain fatty acids. The B section shows the downregulation of junctional proteins is mediated by LPS, binding to, once again, toll-like receptor, zonulin, a protein that activates the EGF receptor through transactivation of protein activated receptor 2 or part 2, thereby inducing protein kinase C, PKC, and or pro-inflammatory cytokines, including most famously interleukin-1 beta and TNF-alpha. I really like this slide. To me, this incorporates everything in that it really speaks about the idea of the gut affecting the liver, the gut affecting the immune system, and the gut really showing the flow chart for clotting activation, etc. So translocation of LPS into the systemic circulation has negative effects on body homeostasis, shifting the host immune defense to a pro-inflammatory state, which has been shown to predispose people to atherosclerosis. LPS is a pathogen-associated molecular pattern and is recognized by innate immune system receptors such as toll-like receptor, a family of highly conserved membrane pattern recognition receptors that are implicated in atheros and thrombotic processes. Together, the data that we share in this presentation indicate the existence of a gut systemic circulation axis, which might contribute to atherothrombosis via a sequence of events, including increased LPS translocation from the gut to the portal circulation and impaired degeneration of LPS in the liver. The LPS can reach the systemic circulation to induce atrial inflammation, ultimately known as thrombus, by binding to toll-like receptor 4. So therefore, describing the mechanism underlying LPS translocation from the gut to the systemic circulation and the ensuing low-grade endotoxemia, the effect of low-grade endotoxemia on atherosclerotic and thrombotic processes, the clinical setting associated with low-grade endotoxemia and cardiovascular complications, and essentially the potential tools to improve gut permeability and eventually eliminate low-grade endotoxemia. So what did I just give in that bit of a pontification? Essentially, we said that the gut, if something translocates like LPS, really needs to get broken down by the liver. So that gut-liver axis has never seemed more important to me than when we talk about the gut cardiovascular health. I know it seems kind of like an oxymoron, if you will, but that gut to liver bidirectionality has always been a question of, in functional medicine, do we do the liver first, detox? Do we do the gut first? And a lot of conversations were housed in the idea of which one had a higher level on a symptomology complaint paper. However, in my 7R program, which I will share with you in some of the succeeding slides, I think we do them both together. So let's look at some of the mechanisms of LPS-mediated atherosclerosis. LDL can cross into an arterial wall and undergo oxidation in a subepithelial space, leading to the formation of oxidized LDL. Oxidized LDL is taken by macrophages, including foam cell formation and inflammatory cytokine productions. That really kind of explains A. B, a lot more going on. Lipopolysaccharide can cross into the arterial wall, either together with LPS binding protein and or by LBP, mediated LPS transfer from HDL, unfortunately, to LDL particles. LPS again binds to the toll-like receptor 4 in several cell types, leading to phosphorylation of toll-like receptor domain adaptive protein. Man, there's a long word, and recruitment of protein 88, MyD88. So essentially, it stimulates this inflammatory marker through toll-like receptor, leading to atherosclerotic plaque. You also have some of the mechanisms of LPS-mediated thrombosis. So when you take a look at this, LPS attaching to toll-like receptor 4, stimulating the adverse effect on monocytes, neutrophils, and platelets really lead to thrombotic plaquing. Here's a slide that speaks to the idea of 3 mechanisms responsible for bacterial translocation and systemic inflammation. So impairment of the gut barrier function allows bacteria and their products to cross the gut barrier, a process known as bacterial translocation, thereby spreading to the mesenteric lymph nodes or entering the bloodstream and reaching more distant organs. Though it has been generally considered a pathological process, this process is common during early life and may aid mucosal antigen sampling in the gut. 3 mechanisms have been suggested to be responsible for pathogenesis of bacterial translocation: bacterial overgrowth, altered gut function, and impaired host defenses. Bacterial translocation increases the number of bacteria, as well as the circulation of endotoxin, such as LPS, that can activate monocytes and macrophages in order to release pro-inflammatory mediators that participate in chronic systemic inflammation, which is actually the hallmark of a lot of the cardiovascular issues. The increased levels of circulating cytokines further compromise the already dysfunctional gut barrier, thereby promoting a further increase in bacterial translocation. So you've got altered gut barrier function, bacterial overgrowth, impaired host diseases, leading to bacterial translocation, the release of an endotoxin like LPS in the bloodstream, this stimulating macrophages, monocytes, and pro-inflammatory mediators. When you look at this slide, you see that the gut can stimulate a lot of different things. And what's critical is there's negative associations with a lack of gut microbiota diversity. So the association of the composition of the gut microbiome and its gut-derived metabolites with chronic diseases. So as you can see, all roads lead from the gut to cardiovascular disease. The heart and the gut are intertwined. Here's a great quote. This is like 10 years old. So this is not a new concept. I'd love to say that it's a new concept. It seems very leading edge, but it's really something that was discussed a decade ago. It's just now come to the forefront. You know, it takes 10 years to be an overnight success. And here's a quote. Patients with inflammatory bowel diseases appear to have a higher risk for coronary heart disease, despite a lower prevalence of classic risk factors, indicating additional links between the gut and the heart. So let's talk about the triggers of increased gut permeability. And believe me, this is just a little snippet of all the things that increase your gut permeability, aka leaky gut. Antibiotics. Now, I'm not anti-antibiotic. I know that almost might sound like a misnomer. However, antibiotics are nuclear weapons to our gut. They're needed in many different instances. You know, my belief is they may be overused at this juncture in our healthcare system. But antibiotics are those nuclear weapons that blow up both good and bad bacteria. It takes months after several doses of antibiotics to be able to repopulate your gut with good bacteria. So one of the things that I always recommend when someone's on antibiotics is without question to take Saccharomyces boulardii, which is a yeast that functions like a probiotic, and it'll help your gut stay populated because the antibiotic won't maim it, kill it, etc. Second thing on the list is acid blocking drugs, PPI, proton pump inhibitors. They're supposed to be taken for 4 to 6 weeks. They're typically taken for months, years, and I have patients coming in for the first time who have even taken PPIs for decades. Acid blocking drugs decrease the stomach acid, which probably doesn't need to be decreased. I think it may be an issue that it could be conceivably misdiagnosed. But acid blocking drugs also increase your incidence of leaky gut and blood-brain barrier breaches. NSAIDs, non-steroid anti-inflammatories, everybody knows, Aleve, Advil, ibuprofen. They do decrease pain, but they impair healing. I believe nutraceuticals decrease pain and promote healing, which is better for the patient. NSAIDs have their place. Unfortunately, NSAIDs are very accessible to patients, especially the over-the-counter stuff, and they're very deleterious to one's overall health. Heavy metal exposure, environmental toxins, which are clearly on the rise year in, year out. We're increasing the environmental toxins which we're exposed to. So these two also lead to increased gut permeability. Concussion, 6 out of 10 people post-concussion have either leaky gut or small intestinal bacterial overgrowth. It is a great example of whatever you do to your brain, you do to your gut. Cesarean birth also, it's a different bacteria in the skin than in the vaginal flora. Therefore, the child is exposed to some non-beneficial bacteria. Liver toxicity, whatever you do to your gut, you do to your liver. Whatever you do to your liver, you do to your gut. 75% of the toxins that flow from the gut to the liver flow through the bloodstream. 25% go from the gut to the, from the liver, excuse me, to the gut via the portal vein. Gut dysbiosis, spoke about that before, the unleveling of good and bad bacteria. And for me, food sensitivities. Food sensitivities are a critical test. It really exemplifies testing and not guessing. The reason you want to test for a food sensitivity is that from the time to ingestion of a food that you're sensitive to the time that symptomology can come up or come out, there's usually a 72-hour lag. That's 3 days. There is no way that I, as a patient, are going to remember what I ate 3 days ago and be able to attribute that to any kind of itchiness, gut and gas and bloating, etc. And as a doctor sitting on the other side of the table, if you will, there's no way I'll be able to ascertain it either. Therefore, you need to test and not guess. Here is a clinical gem, in my opinion. Food sensitivity testing and ascertaining food sensitivities is one of the biggest reasons for chronic hidden inflammation in the patients today. Yeast and bacterial overgrowth to test for candida is a great thing as far as I'm concerned. 97% of yeast overgrowths are attributed to candida. Yeast overgrowths, I like to refer to them as small intestinal fungal overgrowth. Chronic stress, sleep deprivation, chronic inflammation, no alcohol, or limit your alcohol, I should say, no gluten, no dairy, no added sugar, avoid artificial sweeteners, and be very cognizant of your food additives and emulsifiers. Anybody who's seen me lecture knows I love to be able to utilize my Dr. Rob's Gut Matrix. As I said before, the gut is the epicenter of your health. It's your bullseye. 80% of your immune cells are in your gut. It's where your macro and micronutrients are absorbed. So many of us utilize supplements all the time. If we haven't fixed the gut, if the gut is leaky and it's not working and it's not as digestible as it should be, those vitamins and minerals won't get absorbed and many of the patients won't reap the benefits. So one, that's not really a good thing, clearly, but more so than that, two, they won't realize that they work because they're not working, and our protocols will not be utilized by patients for any kind of period of time. Got to test for the gut. You got to fix the gut. So some of the things that you want to look at in the gut is food sensitivities, yeast and fungus overgrowth, dysbiosis, that decrease in good bacteria, all pointed towards leaky gut. Remember, when we talk about the gut, we're talking about the small and the large intestine. Calling the small intestine small is a misnomer because it's 90 to 95% of the length of the intestines. It's an average of 22 feet as compared to the large intestine. That small intestine is small in diameter. The small intestine has a single layer epithelial cell that has the thickness of a wet paper towel. Its sole purpose as your screen door of health from the outside world to the inside world, allows small digested food particles to pass through, vitamins, minerals, water, and on occasion, some pathogens just to keep your immune system sharp. Remember, when something passes that small intestine, it is the first time the outside world meets the inside world. People who have leaky gut have a higher incidence of liver dysfunction because of toxic and chemical overload. People who have increased intestinal permeability have insulin problems, blood sugar problems, insulin resistance, prediabetes, and diabetes. Also have shown to have a higher incidence of obesity. 75% of Americans are overweight or obese. In addition, leaky gut may be the precursor to autoimmune conditions. Thyroid Hashimoto's, as we all know, is an autoimmune condition directly attributable to leaky gut. As a chiropractor, I love to talk about these axes coming up, the musculoskeletal system axes, the gut to joint and the gut to disc axis. Leaky gut leads to an overexpression, as we said before, of cytokines, which increase the incidence of arthritis and joint pain. MMPs are released at the time of leaky gut. MMPSs are matrix metalloproteinases. They're your body's own proteolytic enzymes, which eat fibrocartilage. Your intervertebral disc is made of fibrocartilage. Your meniscus is made of fibrocartilage. Studies showed that 52% of disc surgeries had bacteria translocation. Just take a look at this picture and look how close your gut and your lower back are. Taking it to the next step, the gut-to-brain axis, which I like to refer to as your superhighway to health. Whatever you do to your gut, you do to your brain. Whatever you do to your brain, you do to your gut. And lastly, the expression of LPS, an endotoxin coming through the gut lining, increases the incidence of heart disease by 3 times. I'll say that again. Studies have shown that the expression of endotoxemia, LPS, increases your incidence of heart attack by 3 times. So the KBMO triple screen, I love this Venn diagram in that food inflammation via the food inflammatory test, really talking about the inflammatory markers that food can stimulate. Remember, bad food can be a potentiator for inflammation. Good food can be a potentiator for inflammation. Cardiovascular health tested by the cardiovascular inflammatory test, which we'll get to in the second half of this presentation. And really looking at immune health. When you're looking at immune health, you're looking at the gut barrier panel. There's that override in the Venn diagram, like I said. So let's start to talk about food sensitivities. And let's talk about food sensitivities with the explanation and a little depth in the idea of IgG/C3D. So IgG, we all know, is an antibody, but the key to the testing of IgG for food sensitivities is to test for IgG 1 through 4. Many companies do IgG 1 through 2. It's very critical to include IgG 1, 2, 3, and 4. IgG 3, which is only 7% of the IgGs in your body, can stimulate an old cascade called the complement cascade. And they're able to do that and test for that with the most stable molecular molecule in the body called C3D. So let's take it one step at a time. You want to be able to test for IgG 1 through 4, which is the adaptive immune system, and C3D, which is the innate immune system, 2 different immune systems. So what does it mean if you're looking at food sensitivities, and what effect does it have on your health? Well, food sensitivities have a systemic inflammatory response. Skin reactions are without question part of your immune system. Joint pain, muscle pain, tightness. Sounds like a chiropractic office on Monday morning. GI symptoms, brain fog, anxiety, depression, and mood. Did you know, factoid, that an IRB study showed that when food sensitivities, and only foods that you were sensitive to removed, no change in lifestyle, no added supplements, no change in diet other than the food sensitivities, that anxiety, depression, and mood was the #1 set of symptoms that decreased by the largest amount. Brain fog and gas and bloating was 2. Food sensitivities also happen to have an effect on health, neurodegenerative disease, autoimmune issues, fatigue, body composition issues, and of course, what we're talking about, cardiovascular issues. Food sensitivity may significantly increase the incidence of cardiovascular disease. People with food sensitivities had significantly higher risk of cardiovascular disease, and the experts agree that changes in the microbiome from food sensitivities affected the cardiovascular system. So in this particular slide, we're not only studying and measuring the upstream in terms of exposure via IgG 1 through 4, but the downstream via the alternative pathway, which is pointed out as the complement. Complement will test for inflammation. One of the reasons I like this slide is you look at the left side, you see leaky gut and progress. On the right side, you see a much smaller gut, much thinner gut. That gut has autoimmunity. If you have autoimmunity in your skin outside, you may have autoimmunity at the epithelial layer inside. And if that's the case, it's going to take a longer period of time to fix that autoimmunity at the gut level. So we talked a little bit about the complement system. It's an evolutionary older part of the human immune system, consists of a family of proteins called C3, which can activate one another to drive inflammation in what is called the complement cascade. It's part of the innate immune system, can also be recruited and brought into action by antibodies generated by the adaptive immune system. So this complement activation, C3D levels are significantly higher in acute myocardial infarction patients, and increased levels of C3D in AMI patients occurred previously to classic markers of myocardial damage. C3D is leading candidate for early biomarker of myocardial inflammation. So the FIT test technology really shows enhanced sensitivity and accuracy because it's a dual purpose technology. It's testing both the adaptive and the innate pathways. So here was an IRB study of an irritable bowel syndrome study. So number one, IBS severity score. They used a VAS score, visual analog scale, asking numbers in reference to abdominal pain, the amount of days, bloating, and bowel habit. They've got an interval group. They have a control group. There's a dramatic decrease from the interval group, intervention group, versus the control group, just taking the foods out. No surprise there. However, what really caught my attention was the effect on objective systemic blood markers like homocysteine. Homocysteine in the intervention group decreased dramatically in comparison to the control group. So homocysteine was affected by food sensitivities, and then, of course, the removal of food sensitivities. Add that to your armamentarium. C-reactive protein, also from day one to the end of study, was fascinating in that the intervention group was decreased 5 times more in the C-reactive protein, which was the tissue inflammation marker. So why do I like to use the FIT test? And what is the reason that it's so easy for the doctor to understand and to elucidate the findings to the patient? The color coordination makes it just so easy. So I immediately look at it and I see red. Red is +4, inflammation galore. Orange is almost red. Got to stop that as well. Yellow, slow the roll, slow it down a little bit. So red is 4, orange is 3, yellow is +2. And then testing for food additives. This makes it easy for the doctor and the patient to be able to collaborate on their next steps. So many people ask why increased intestinal permeability, why test for it? Well, one, defective epithelial barriers are linked to a myriad of chronic diseases. Epithelial damage to the skin and mucosal barriers lead to food sensitivities, inflammatory bowel disorders, celiac disease, and many diseases that are attributed to changes in the microbiome, such as autoimmune issues, metabolic disorders, and neurodegenerative disorders. So basically, actually, a leaky gut report improves patient compliance and motivation because intestinal permeability treatment can take time and symptomatic improvement may not occur until months into treatment. It's your baseline. And I believe that a gut barrier panel is a baseline test. So when you measure baseline severity, it gives some indication of the treatment duration needed to address. It also is great for follow-up testing and can be done to assess progress objectively. So when you mix the objective and the subjective, you can really see where the patient is. Because unfortunately, I found out that sometimes we don't get credit for where a patient was to where they are sitting in front of you right now. This really does beg the question then, when does a provider need to charge or to order the KBMO gut barrier panel? Well, clearly, this is not an all-encompassing list. These are some leaders. One of the bigger leaders to ordering the test would be food sensitivities, IBS and IBD, celiac disease, small intestinal bacterial overgrowth. I believe is going to be in the next 3 years when we come back and have this same conversation as common as leaky gut, post-concussion. Everybody who hits their head should take a gut barrier panel test. I'm going to go back one step. SIBO. Leaky gut does not necessarily cause SIBO. SIBO can cause leaky gut. If you have some digestive and skin issues, that's also a great time to want to test. Weight loss, weight gain, autoimmune conditions, joint and disc injuries. I made that case previously. Brain fog, fatigue, neurodegenerative conditions, autism or ASD, liver dysfunction, blood sugar issues, and of course, cardiovascular concerns. Well, here is my prized gut barrier panel. Let's look at the left side and let's look at Candida. What is Candida? Candida is a yeast. Everybody has yeast in their gut. It's the overgrowth, the overexpression, the aberrancy of the yeast that leads us down that slippery slope towards dis-ease. Zonulin. Zonulin is a protein enzyme that functionally pulls apart the tight junctions. Occludin is actually raised when there's tearing of the fibers of tight junction. And LPS is an endotoxin that, when it gets past the gut and translocates, brings gram-negative bacteria, which is 80% of which is pathogenic, and causes chaos and mayhem. Let's go over 2 columns to IgA 1 and 2. IgA is an antibody that's usually seen elevated at the time of injury to specific mucosal linings like the lung, the mouth, and of course, the gut. It's an early onset. So here we see Candida having IgA elevated. Interestingly enough, Candida also has an elevation of IgG 1 through 4. The most prominent antibody, which takes a little time to come out, 75% of the antibodies are IgG. We know that it passes the placenta and gets to the fetus. And also IgG takes about 14 to 21 days to come out. So now we see with IgA and IgG, both antibodies are out, and Candida has probably been elevated for a period of time. In addition to that, C3d also indicates that it was elevated via Candida. So the innate immune system was activated and inflammation is being raised. So Candida is raising both the innate and the adaptive immune system, raising inflammation at the gut level as well. We need to address that. Zonulin, interestingly enough, is only elevating IgA 1 and 2. Therefore, it's just at the gut level and probably hasn't been raised for a long period of time, as evidenced by the fact that occludin hasn't been raised. Unfortunately, LPS has a positive to IgG and C3d, so it's been elevated for a period of time, and it's also causing a vast number of inflammatory markers to increase for sure. So Candida, it's a type of yeast that normally lies in small amounts in different parts of the body, mouth, skin, and gut. But when the environment is right, yeast can multiply and grow out of control. Here's a big point. Grows when good bacteria is suppressed or their immune system is weakened. Fungi in the gut influence health and disease. Fungi thrive in a healthy gut, can cause intestinal damage. Fungi leads to irritable bowel disease. Immune system typically can keep fungus in check. When the system is off balance, disease can occur. Candida albicans typically elicits a strong immune response. Yeast in its normal rounded state allows people to remain healthy. And lastly, Candida's invasive form causes intestinal damage that can resemble IBD once again. Zonulin is a protein that can open tight junction proteins. Zonulin gets elevated and released from aberrant intestinal bacteria, and gliadin, which is the gluten enzyme, or I should say the gluten protein, which begs the question, do you eat gluten? My answer is a resounding no. If you have celiac disease, certainly no. If you are sensitive to it, absolutely no. And if you're not, it's not suggested, because zonulin will be elevated. Gluten does cause inflammation in the gut. Our gluten in America is hybridized. It's been exposed in most instances to glyphosate. I think it's a non-starter. So I don't know if I'm the most popular guy when I say that, but my goal isn't necessarily to be popular. My goal is to be heard. So let's take an overview of zonulin. It's a protein synthesized in intestinal and liver cells. It's a key biomarker for intestinal permeability. It's the only reversible regulator of intestinal permeability. Elevated levels of zonulin are associated with a multitude of conditions like autoimmune disease, celiac, adult glucose intolerance, inflammatory bowel disease, RA, MS, diabetes, and even obesity. Higher levels of serum zonulin may be associated with increased risk of obesity. Also, higher levels of zonulin are associated with higher waist circumference, diastolic blood pressure elevation, fasting glucose, and increased risk of metabolic disease. So for me, zonulin is a baseline marker because all of these markers can be elevated. So I don't think it's a specialty marker anymore. I mean, when your blood pressure is up, your fasting glucose is up, metabolic disease, like metabolic syndrome, your waist is up. I want a marker to know and test for. So we can attribute a lot of these things to aberrancy or compromise of the gut lining. Are we really testing for zonulin, or is it better to test for the zonulin antibody? Well, when you test for the zonulin antibody, it eliminates the cross-reactivity of the protein enzyme, which eliminates haptoglobin, properdin. You also have a lower positivity rate because when you're testing for all these things, we start thinking that it's always zonulin. The positivity rate eliminates zonulin blocking and low positivity rates. The last bullet, we now know that the poop test or fecal matter does not really give an accurate zonulin test. Serum or blood spots are much more accurate. As a matter of fact, the NIH has said the blood spot is without question a statistical virtual tie with blood serum. What's great about the blood spot is it's quick, it's easy. Some docs are not allowed to pierce the skin. And what's great about the blood spot, it allows for a virtual encounter with a patient via testing. Occludin is a key biomarker for intestinal permeability. Its barrier function to regulate transport. Occludin is open in response to zonulin. Here's a clinical gem. Occludin is essential in tight junction stability and barrier function. Together, zonulin and occludin are the gatekeeper of these tight junction proteins. When they function properly, they keep the bad guys going through the intestinal tract and out the back, as opposed to getting through permeable intestinal barriers and getting into your bloodstream and creating havoc. Here's one of my most favorite sides. Here's this LPS modification stimulating NLRP3 inflammasome. LPS stimulates toll-like receptor 4. We talked about that before. LPS affecting toll-like receptor 4 attaches to MyD88, which stimulates NF-kappa B. NF-kappa B leads to the release of inflammatory cytokines. In addition, LPS attaching to toll-like receptor 4 also stimulates the NLRP3 inflammasome. So you've got a boatload of inflammation. But in the interim, it also adversely affects the mitochondria. It causes mitochondrial dysfunction. I believe that mitochondrial dysfunction is now elevated itself to the maybe to a paramount conversation in the functional medicine world. Mitochondrial dysfunction is attributed to fatigue. Mitochondrial dysfunction is attributed to a key component of neurodegenerative disease. All of this happens in the gut, many of which is attributed to the release of LPS. In addition to LPS stimulating and attaching to toll-like receptor 4, that also enables it to stimulate toll-like receptor 2. Toll-like receptor 2 stimulation leads to plaquing. So LPS, the expression of, leads to inflammation via the toll-like receptor 4 and toll-like receptor 2 plaquing. Is it any wonder that the release and the translocation of LPS leads to 3 times the increase in heart attacks? So let's get a little granular. Let's take a step back. Here we have gram-negative bacteria coming out with LPS, attaching the toll-like receptor, which stimulates MyD88, which also activates NF-kappa B, which leads to the release of cytokines. LPS is a major outer surface membrane components present in almost all gram-negative bacteria. It holds gram-negative bacteria on the outside of the inside of the intestinal wall. Many of the percentage, 80% of the gram-negative bacteria are pathogenic. LPS is a stimulator of the innate immune system. It's an endotoxin stimulating a large number of inflammatory cytokines. It can actually cross the blood-brain barrier. It's present in triglyceride-rich VLDL and systemic blood flow. And here's a critical gem. It's a component of biofilms. Biofilm, wrapping up bacteria. Biofilm is like plaque of your gut. 80% of your bacterial infections are biofilms, according to the NIH, in your gut. And that can be attributed to, or is partly attributed to, the release of LPS. LPS also has an adverse effect on joint, immune system, liver, the brain, lung, metabolic disorders, and even thyroid. LPS also damages muscle. Many people have an expression of LPS, have muscle discomfort. So gut permeability leads to endotoxin absorption. So here's my 7R action plan. Let me go through this with you. Let me share R number 1, which is reset. Reset your diet, your lifestyle, and your mindset. In your diet, keto, anti-inflammatory, Mediterranean diet, flexitarian. You want to decrease stress, increase exercise, 15,000 steps, add resistant exercise. We all know that muscle mass is the longevity organ. Increase flexibility training. Maybe add some MCT oil, C8 and C10. They metabolize more efficiently in the ketone energy than C12 lauric acid. Add some fiber. The average American consumes 8 to 15 grams of fiber. We want to get them up to 35 to 50. 70% of Americans are deficient in magnesium, and we want them to avoid GPS and DNA. GPS, no gluten, no ultra-processed food, no added sugar. DNA, no dairy, no nicotine, no artificial sweeteners. You want to remove unwanted pathogens. This removal is typically offending substances from the diet. In general, this phase of the 7R program is dealing with food sensitivities. According to many estimates, as many as 60% of the population suffer from undetected food sensitivities. Thyme oil kills infections. Oregano oil, antioxidant, bacterial, viral, and fungal. Berberine is for a train wreck patient, dysbiotic, dyslipidemia. It also stimulates the AMPK pathway, which regulates an array of biological activities that normalize lipid, glucose, and energy imbalances. Berberine is antibacterial, inflammatory, and immune-enhancing properties. Allicin garlic is your natural antibiotic, if you will. Serum bovine immunoglobulins are also involved in that. They're the mop of your gut. And lastly, a biofilm buster, which will break up those biofilm around the bacteria. So you want to replace needed digestive enzymes, stomach acid, pancreatic enzymes, and bile. Replacing and augmenting vital digestive chemistry allows the patient to improve digestion absorption, the primary role of the gastrointestinal tract. Part 4, or R4, is regenerate. This is where you use your plethora of nutrients that are pleiotropic, in that they're going to help heal and seal the gut lining and also create an anti-inflammatory milieu in the intestinal region. Glutamine, omega-3 fish oils, apple pectin powder, aloe vera, okra, glucosamine HCl, zinc carnosine, which is great for tight junctions, MSM, slippery elm bark, and maybe my favorite, pro-resolving mediators, which allow for the resolution of inflammation. You want to re-inoculate with pre and probiotics. Prebiotics are the critical element. Prebiotics have shown to reduce body weight, body fat, trunk fat, interleukin-6, which is quite inflammatory, decrease serum triglycerides, increase bile acids, and good bacteria. So you want to feed a probiotic, in that your prebiotic feeding a probiotic makes a postbiotic. You want to reintroduce certain foods. You're going to put in your foods that you're sensitive to one at a time over a 3-day period and see if symptomology comes out. Remember, food sensitivity is not removed for perpetuity. You can try and put it back in. You can either retest, but the things that you still want to avoid are fried foods, any food that you're sensitive or allergic to, and your usual GPS and DNA. And lastly, you want to retain your health and your GI integrity. You want to do so with what I call my Super 5. Always adhere to good diet, lifestyle, and mindset, an excellent gut restorative formula, a pre and probiotic, a fruit and green drink, and of course, a complex collagen formation. For me, collagen is a great tool because it helps with musculoskeletal injuries. It helps with gut health. I think collagen is a choice protein. If candida is elevated, and just candida, you can use caprylic acid, C8, oregano oil, berberine, garlic, serum bovine immunoglobulin, and probiotics. Zonulin and occludin, good quality probiotic, zinc carnosine, L-glutamine, collagen peptides, curcumin, glucosamine HCl. So for me, we know that more than 2/3 of patients have symptoms of diseases that are gut-related. So therefore, the most effective clinical outcomes across all disease spectrums can result from the normalization of gut function. So let's talk about early detection, how critical it is. Most people don't get tested until disease is already causing a problem. Therefore, early detection of biochemical markers allows for early intervention and the ability to prevent disease. 50%, factoid, 50% of heart attack patients have normal standard lipid profile the day of the heart attack. Another factoid, heart disease is the leading cause of death for both men and women. This is the case in the US and worldwide. I grew up in New York, still live in New York. One of the things we like to use colloquially is, are you kidding me? Heart disease, without question, is the leading cause of death in the US for the past century. The AHA said that on a test, 49% of Americans correctly identified heart disease as number one, which meant that more than half were still unaware of cardiovascular disease being the number one killer by far in America today. One of the health educators came up with this quote. I thought it was worthy of sharing. The question is, well, why don't Americans know? Because people may not want to acknowledge heart disease as a leading cause of death, because many risk factors for heart disease require lifestyle modifications that are hard to do, such as losing weight, stopping smoking, and consuming a heart-healthy diet. Basically, they did not want to change their lifestyle. We've got that memo every day in our office. So I'm a big proponent of testing, not guessing, or test, don't guess. Let's look at the CIT test, cardiovascular inflammatory test. Let's look and test for lipids. Lipids is total cholesterol, which measures the amount of cholesterol and all cholesterol containing lipoproteins. LDL-C, which tests for or defines the amount of cholesterol and atherogenic low-dense lipoproteins. HDL, or HDL-C, is the amount of cholesterol and high-dense lipoproteins. Higher levels of HDL are associated with reduced cardiovascular risk, but not all HDL is good, as well we know. Triglycerides, or elevated levels, increased cardiovascular risk factor by altering lipoprotein metabolism. Non-HDL-C, subtract HDL cholesterol number from the total cholesterol. ApoB, critical marker, beeping red light, test for ApoB, a major protein in atherogenic particles. It is a strong predictor of cardiovascular disease. Lipoprotein A, or Lp(a). This is your heart attack genetic marker. Elevated levels are present in 20% more, it's like 25% of the population, which are genetic independent risk factors for cardiovascular disease, and lipid ratios. These ratios are stronger risk factors than the actual tests alone. These are a great add to anybody's blood lab toolbox. Inflammation, high sensitivity C-reactive protein, so it's acute phase inflammatory protein associated with atherosclerosis after excluding other causes. Metabolites, metabolics, you got glucose, which is a snapshot in time of your blood sugar, hemoglobin A1C, which assesses 90 to 120 days of your average blood sugar, with an emphasis on the 50% in the last 30 days. And homocysteines are typically associated with vitamin B deficiency and increased risk for cardiovascular disease and dementia. So let's get into the KBMO cardiovascular test and how it's put together. So there's advanced lipid testing, which tests for direct LDL, big takeaway, direct LDL, HDL-C, total cholesterol, triglycerides, non-HDL-C, some specific lipid ratios, ApoB, and Lp(a). The metabolics is glucose, hemoglobin A1C, homocysteine, and inflammation is going to be tested by high sensitive C-reactive protein. So here you see the test. You see most of the markers here. The next slide will have homocysteine. Red is over the range. Yellow is in a concern range where you've got to yield and proceed with caution. And green means go forward. Things are good. And there's your homocysteine marker. So why LDL, or why direct LDL? Well, direct LDL distinctly measures LDL cholesterol in the blood, whereas most lipid panels use LDL cholesterol estimating using an equation involving other cholesterol measurements. So this is the equation that's used. The direct LDL cholesterol is up to 20% more accurate. I think that this is a game changer right here. ApoB, which is, I always like to refer to it as your boat carrying the bad passengers. It's the single best cholesterol predictor of risk for heart attack and stroke. Every particle that dangers cholesterol is wrapped by ApoB. Less than 5% of Americans have been tested for this. Inappropriate. LP little a, just say it right now. Less than 1% of Americans have been tested for LP little a. It's sticky lipids. It's where there's turbulence in arteries. Glue things together can cause blood clots that can block arteries. LP little a levels affect up to more like 25% of the population. If you have it, you have to test your relatives to see if they do, suggest it to them, because over 40% of relatives of somebody obviously related to an LP little a have the marker. Unfortunately, statins raise LP little a. Statin use is also associated with 52% increased prevalence of calcified coronary plaque compared to non-users. So here's the ratio. Total cholesterol, HDL ratio is a better indicator of plaque impact than anything else. You've got your cholesterol to HDL ratio on your right. You have your plaque impact on the left. So you're able to see that ratio. You'll see there's an optimum regression, suboptimal, moderate, high, and very high for progression. HDL-C over triglycerides ratio, 70% plaque-forming patients have insulin resistance. Time out here. Let's slow that roll. Blood sugar is really probably the bane of our existence, I should say. High blood sugar, lots of insulin really is the most inflammatory marker. Cholesterol is more of a friend than a foe. It's the aberrancy in the cholesterol that poses the issue. 90% of insulin-resistant patients go undiagnosed. HDL-C over triglyceride ratio predicts this sooner than fasting glucose or even hemoglobin A1C. Here's your insulin-resistant risk and your ethnicity. High sensitive C-reactive protein is a heart attack marker. Health conditions associated with inflammation. Remember, inflammation really is my mantra. I want to manage and modulate inflammation. Inflammation inside causes inflammaging, one of the hallmarks of energy, decreasing our longevity, health span, and even our vitality. High sensitive C-reactive protein, it gets a strong contribution from excessive fat stored in and around the organs called visceral fat. Visceral fat is much more inflammatory than subcutaneous fat. Visceral fat also increases interleukin-6, which increases damage to the blood-brain barrier. High sensitive C-reactive protein is also commonly seen in prediabetics and diabetics. And here you've got your markers. You really want below 1. 1 to 3, people say, okay, but no, it's chronic inflammation at risk for arterial disease. 3 to 10 is a problem, and over 10, just it's chaos and mayhem. Glucose and A1C, as I said, fasting glucose is a snapshot in time. It's normal for 20 years or more before a diabetes diagnosis, typically. Hemoglobin A1C is that average over 90 to 120 days and doesn't rise until 10 or more years before diabetes diagnosis. What I find interesting about this classification of normal, prediabetes, and diabetes, they correlate. So for instance, let's take normal, less than 100. I want people less than 90. Hemoglobin A1C less than 5.7. You need to be less than 5.4, otherwise you have brain shrinkage. So it may be normal, but it may not be optimum. Homocysteine, normal breakdown of proteins. Elevated levels associated with higher risk of ASCVD and dementia. Here are your markers. There are typically no symptoms in homocysteine until it's too late. Commonly attributed to an inability to have methylated B6, B9, B12 that helps detoxify homocysteine. Early detection and treatment is without question essential. So let's take a look at what supplements might help. Here is my Dr. Rob's blood sugar protocol. Eat low sugar diets, eat clean, your GPS and DNA come again. Alpha-lipoic acid, great for blood sugar regulation. It's an antioxidant. It's the only one that works with the watering the fat part of the cell. Glucose support chromium, taurine, acetyl L-carnitine, EGCG green tea, also outstanding ad, berberine, and pre and probiotics. Make sure your probiotics for blood sugar regulation or Akkermansia B subtilis. They've got a robust amount of studies behind them. And of course, omega-3 fatty acids. Omega-3 fatty acid testing, looking at omega-6 versus omega-3, is also a great marker for aging. Homocysteine protocol, comprehensive formula supplying a biologically active form of folate, B vitamins, and NAC. You want your methylated B vitamins. If your blood lipids are also elevated, you would want to add niacin, red yeast rice, phytosteroids, and pre and probiotics with the Akkermansia bacillus subtilis, your spore probiotic. Cholesterol, lipids, dyslipidemia, LDL, niacin, and omega-3 fatty acids. Interesting, niacin is shown to increase the production of ApoA1, which carries a good cholesterol around, as well as omega-3 fatty acids. The combination of them does not work as well. They're thinking now that niacin and omega-3 work through the same pathway. Nattokinase, our superstar for LDL, multivitamin, multimineral, red yeast rice, vitamin D3 with K2, panathine, phytosteroids, and of course my 7R action plan. Gut is critical because it can help with cholesterol disbursement. If you want to lower Lp(a), there's a lot of argument that nothing decreases Lp(a), no drug does. I think we all know empirically that lifestyle and nutritional supplements have a good outcome with Lp(a) or an improved outcome. Those supplements are L-carnitine, coenzyme Q10, ginkgo biloba, resveratrol, curcumin, flax seeds, and limit your carbohydrates, please. They are the macronutrient that we need to watch. Combining exercise has shown to decrease cardiovascular risk. Combining exercise, we're talking about the combination of aerobic and strength training, which lowers heart attack risk, heart disease, as effectively as aerobic-only routines. So the exercise groups in this study that improved aerobic fitness and strength had much less of a cardiovascular risk. I'm a big believer in strength training. I think strength training enables you to build muscle mass, which is the longevity organ. Muscle mass also allows you to dispense with blood sugar more efficiently. Let's look at some case studies as we get towards the finish line. The gut barrier panel. Here we're looking at a positive for Candida, both in IgG 1 through 4, C3D, and IgA 1 through 2. So this individual has a yeast overgrowth for a period of time, as well as an expression of LPS over a period of time. This person's inflamed, as evidenced by the cardiovascular inflammatory test results. Direct LDL is elevated, triglycerides are elevated, ApoB elevated, Lp(a) elevated, HS-CRP elevated, and hemoglobin A1C elevated. These are elevated to an extensive level. I mean, a lot of practitioners may look at drug modifications at this point. However, we had to fix the gut, and we also had to simultaneously give a lipid protocol. So I did a modified 7R program for the first month. I gave him caprylic acid, oregano oil, berberine, garlic, serum bovine immunoglobulin, lactobacillus strain, GI Restore formula, limit carbohydrates. Your lipid protocol then started in months 2, added on through 6, niacin, omega-3, pro-resolving mediators, coenzyme Q10, resveratrol, natto, pre and probiotics, and I continue with my 7R action plan. 6 months after the program started, of course, this patient was extraordinarily compliant. The Candida and the LPS all were negative, and the cardio-inflammatory testing resulted in direct LDL, triglycerides, ApoB, LPA, C-reactive protein, and hemoglobin A1C, all in a normal range. A dramatic drop in hemoglobin A1C and Lp(a), all from changing their lifestyle, giving them supplements, and getting them to walk around the block a little bit. Case study number 2, gut barrier panel. Here we've had zonulin that was elevated, early elevation, tight junction compromise, but LPS was rampant positive in both IgG 1 through 4 and C3D and IgA 1 through 2, which did result in an increase in cardiovascular inflammatory, which showed direct LDL elevated, triglycerides, ApoB, Lp(a), HSCRP, hemoglobin A1C 6.3. This patient had tried multiple approaches in statin therapy. They were on a 2-year journey. They were off the drugs. They said this was their last stop. They were just going to roll it out after this. Well, I put together a gut protocol modified 7R for the first 3 months, pre and probiotics, polyphenols, omega-3 fatty acids, pro-resolving mediators, ketone bodies, gastrointestinal restore formula, extra virgin olive oil, lipid proteins. Months 4 and 6, I added niacin omega-3s, red yeast rice, L-carnitine, curcumin, phytosteroids, and I continued with the modified 7R program. 6 months later, bingo, gut is restored to its pristine condition. Cardiovascular inflammatory tests, direct LDL, triglycerides, ApoB, Lp(a), again under 33. C-reactive protein, normal, and hemoglobin A1C almost dropped a point. A dramatic drop once again. So, some of the cardiovascular inflammatory testing advantages are it's a dry blood spot, it's a finger spot, it's a serum test. It has a validated 96% in agreement versus a pure serum blood test. It's stable for 14 days. It gives patients another major screening tool to assess the overall health and longevity that they want to attain and the doctors want to share with them. So when you look at this flow chart, the food inflammatory test, FIT, the immune health getting it via the gut barrier panel by KBMO, and the cardiovascular health via the CIT, cardiovascular inflammatory test, all is going to lead to better health, longevity, and vitality. So here's the CIT test kit. You've got ease in which it opens up. It can be done in your office. There's a blood spot tutorial. It's great to send through the mail to the patient so you can, again, do your virtual consultations. I appreciate James White, the CEO of KBMO. In that, I'm going to leave this up for a moment because he's allowing an introductory discount and an account sign up. For him to do this through A4M, we all greatly appreciate it. Everybody take a quick look. Just want to say that this has been my pleasure. I really enjoyed being able to share some takeaways. Hopefully, I shared some scientific implementable parts that you can start on Monday morning if you will. Anybody interested, they can take a look at this slide. They can follow me. Again, KBMO Diagnostics, new products. If you're interested, that's how you can email the CEO. He's out there. He'll talk to you. And one more time. And once again, it's been my pleasure. Remember, a mind stretched by a new idea never returns to its original dimensions. Oliver Wendell Holmes. Hopefully, everybody has some stretch marks. I'm available if anybody has any questions. I appreciate all your time.